Hi everyone, I'm Beth Overturf, a third-year occupational therapy student, completing this presentation as a part of my capstone. One of my objectives is to increase the role of occupational therapy in primary care. So for our objectives, I have a lot of information and resources in these slides. Much of this information is likely known, but I want to include it for context as an easily accessible resource. I'll try not to go too quickly, but I will be going a little bit faster pace just to make sure that I'm not keeping you here for too long. After this presentation, participants will be able to identify what is OT, what's OT's role in primary care, with a focus on our role in chronic disease management. And when we talk about chronic diseases in this presentation, I'm referring largely to the conditions that have a large lifestyle risk factor component, such as type 2 diabetes and hypertension. We'll focus on how OTs and PCPs collaborate in primary care, and we'll also talk about challenges and opportunities for growth related to OT's presence in primary care. All right, first, quick little history on our profession. OT roots are traced back to World War I, when the providers, then called reconstruction aides, ultimately becoming OTs, treated soldiers for their physical and psychological injuries using engaging activities. 9 years after our profession was named, the 40-hour work week was invented, and then the word occupation largely became associated with what people do for work. So since then, this has been kind of a point of confusion, a little bit of a barrier for patients and colleagues, understanding exactly what it is OT's role is. There's been discussion of a name change with no resolve. That's a topic for another time. So occupation, defined by Webster and in context of what we do, is how you spend your time, which is quite broad. Regarding the soldiers from World War I, engagement in craft activities helped to shift patients' focus from war-related physical and emotional traumas to focusing on rebuilding function. For example, someone who had lost fingers would relearn compensatory or remediatory strategies to complete tasks like sewing. Various grasps and movement patterns involved in these crafts would carry over to their purposeful roles upon return home to their families. At the core of OT interventions are what is valued by the patient. This increases autonomous motivation to build new skills needed to increase function. It also helps us to build rapport with the client, which is essential for the therapeutic relationship. Here are common questions focused on in OT evaluations as we learn a lot on what to focus on and how to frame our treatments. Since World War I, the profession has evolved quite a bit. Today, our accrediting body is the Accreditation Council for OT Education, or ACOTE. According to ACOTE, the curriculum requirements include substantial foundational knowledge in biological, physical, social, and behavioral sciences and how they impact function and occupation. Many of these standards are relevant to facilitating chronic disease management, but I highlighted some of the most important, in my opinion, to this setting. I don't want to spend a whole lot of time here. These slides are available if you would like to reference them at any point. So here are some terms within the domain of our scope. I'll explain how we apply them in our OT process in the following slides. This language is important because it paints a picture of what our skilled observation is honed in on, from the chart review to a home evaluation or in-clinic session and care planning. This information is gathered by patient report and skilled observation. From a top-down view, the domain starts from more complex and is essentially broken down farther into simpler factors. This collected information informs our activity analysis, helps with problem-solving, client-centered solutions in collaboration with the client. So at our core, really, we are biopsychosocial detectives. When you care about meeting a healthcare standard and things are just not being met, these biopsychosocial nuances, particularly when gleaned from an in-home session, when you're in the patient's natural setting, can be a huge asset. So here's how those terms play into our process. Our end goal is always a discharge. That is, to provide the patients with all the tools and self-efficacy they need to manage their own health independently, allowing them to thrive and engage in what's most important to them. When life changes and there are new barriers, we're always here for a re-eval if needed, but our true intention is to increase patients' functional independence. Brief background on chronic disease for context. The burden of chronic disease on a systemic, community, and individual level is undeniable. Chronic disease is defined by the CDC in part as something that limits activities of daily living, which, if that is not the scope of OT, then I do not know what is. More information on the salience of addressing chronic disease here. This is only going to continue unless there are actionable steps taken to alleviate the burden of chronic disease. Fortunately, there is a lot of evidence on what we can improve and reduce the impact of chronic disease. These are evidence-based modifiable risk factors that impact chronic disease outcomes. Research also says that self-management interventions are most effective for improving chronic disease outcomes in primary care setting. This article is a systematic review of randomized control trials of effective chronic disease interventions used in the primary care setting, which include the following steps. These are all interventions that physicians can do. It's also doable by other members of the healthcare team, including occupational therapists, physical therapists, and nurses. Speaking for OT specifically, our education and training in mental health, behavioral health, medical conditions, rehab, and lifestyle management makes us versatile and able to focus on these interventions with patients. We have a unique lens viewing patient context of their environment, including their family, role, employment, culture, and value system, as well as the habits, rules, and routines that comprise their daily lives. Those evidence-based interventions highlight why our wide scope really works well with chronic disease management. Two of the biggest roles of OT in chronic disease management are increasing patient functional independence through building self-management skills that reduce chronic disease, as well as decreasing physician burnout. We can address issues that don't require the skill set of a physician, increasing the availability of physicians for patients who require complex medical decision-making. All this to say that although OT's role in chronic disease management is still, quote, emerging, it's a function of the lack of understanding of the full scope of OT, more recent demand for chronic disease to be addressed, and slow nature of evidence being implemented into practice. This is from an article piloted OTs in a primary care setting at the Mayo Clinic of Arizona. OTs assisted patients with the following interventions. Here's feedback from the study. Overall, physicians initially did not value the role of OT in primary care at the beginning. By the end, the majority of them felt strongly about the importance of OT's role in the primary care setting. This is similar to the slide discussed when I was touching on our process, but I tailored it more to reflect our role in chronic disease management. We take a holistic approach to promote health, well-being, and prevention for people across the lifespan who experience injury, illness, and disability. OTs are trained to identify and address the physical, mental, and behaviors that impede independence, including barriers to adherence. Here's a list of CPT codes that were used in that study. And here's an example of how our role varies from the physician. It also demonstrates how our roles complement each other. For example, in medication management, physicians are looking for like an HbA1c to change. We're looking for consistency in the change of sustainable habits that relate to the change of the HbA1c. When a habit isn't working, we're able to help modify that to increase in self-efficacy. So as far as opportunities for growth go, interprofessional relationships are huge. Helping our interprofessional team to understand what we do is going to be critical for us getting referrals and also being able to successfully determine how to help patients. It's also important that in each primary care setting, we figure out the gaps of care depending on which care members are available so we can best serve the patients. Finding primary care clinics that operate within Medicare Advantage and shared savings programs will help us have more sustainable services because those encourage the providers to have better health outcomes. They get reimbursed for the amount of hospital readmissions that are decreased, essentially. Another option instead of CPT codes is incident to billing services. Thank you for listening to my presentation. I hope you enjoyed it and have a wonderful day.